personally don't. I look at it as a potential risk, but if there are quality control points in place, it should not be an issue. But I know that blue-green algae is being looked at by epidemiologists more closely than ever, given how it is now being shown to be responsible, whether that's coming from seafood consumption, spending time or recreating on lakes or freshwater bodies where there's these algae blooms. It's really being linked to these outbreaks, so to speak, over a short period of time of ALS and Parkinson's. So it's clearly linked. But I would be concerned about any algae someone's consuming that is called a blue-green algae. I want to make sure that there was quality control in place to make sure you weren't getting cyanobacter.
Okay, and can you repeat the fructose intake amount that you recommended, or the upper limit? And do you have recommendations on how you communicate with your patients on how you would eat fruit in your diet?
Yeah, sure. That's an easy one. Again, Robert Lustig, who I'm sure many of our participants today are familiar with, he has done some unbelievable work at the University of California, San Francisco on fructose and its contributions to diabetes and issues in pediatric health. He's got some great papers. He's got his own website. So Robert Lustig and others, not just Robert, they've shown that we have a limited ability to safely or in a healthy way metabolize fructose. Some is okay, but it's around 10 grams per meal. A banana has typically around 10 to 11 grams. So that's about it, what people would be able to tolerate, and around 25 grams per day. And in terms of how I work with patients, or how would I advise a clinician, I would have patients consume berries and citrus fruits. If you want a really simple message, berries and citrus fruits tend to be much, much lower in their fructose content than fruits such as grapes, mangoes, and pears. If we're eating a mango and having dried fruit, or we're using those types of fruits 2 to 3 times per day, it's very easy to consume an exceedingly high amount of fructose. So I try to have clinicians, and for those populations that I work with, I really try to get them to eat lower fructose fruits, not use any sweeteners. Obviously, that's a very easy way to minimize fructose. Don't drink fruit juice. And when you do those things, then the small amount of fructose that a patient might get from something like, a sweet potato might be 1 to 2% fructose. The rest of it's glucose. A baked potato is about 100% glucose, and rice is 100% glucose. So there are these choices where it's almost entirely a glucose-based carbohydrate or food. And those are the better ones to go with.
Does the oxidation of saturated fats not produce free radicals, which would cause mitochondrial damage?
Exactly. Saturated fat is very resistant to oxidation. It doesn't have any double bonds. So once a fatty acid, once it's free of those double bonds, then it's extremely resistant. Even olive oil, which has one double bond, but also contains some unique substances, often in close proximity with the fatty acids, even that is very resistant to oxidation. It's when you get into the polyunsaturated, or the presence of multiple double bonds, that there's ample room for oxygen to react with those fatty acids. And that's where things take a turn for the worse in a hurry.
Is there a direct relationship with mitochondrial health and insulin resistance?
Well, that would be an association at this time. There are certainly researchers that feel the two do have crosstalk, or there's a contributing factor of mitochondrial issues to insulin resistance. But at this time, we tend to see people with diabetes have much higher levels of mitochondrial pathology. Some of that may, as I explained earlier in the talk, the mechanism behind that would be dysglycemia, higher levels of sugar in the bloodstream, driving the glycosylation of proteins in the body, higher circulating levels of fructose and the metabolism of that fructose, contributing more methyl glyoxal to mitochondria and causing that, the loss of mitochondria through that mechanism. So I think that it's certainly a plausible mechanism, but at this point, diabetes is considered to be associated with mitochondrial dysfunction, as opposed to one being seen as the cause of the other.
Okay, and there's looks like we're close to time, so just